Bone stress injuries can be a life-altering injury. Let's make sure we don't mess them up from the start. My name is Nathan Carlson. I'm a running specific physical therapist. Let's dive into today's video. When a runner develops a bone stress injury, the first thing we want to figure out is if it's in a high risk or low risk site. Low risk sites include your tibia, most of your metatarsals, your sacrum and your pelvis, with common high risk sites being your femoral neck, your anterior tibial cortex, your fifth metatarsal, and your navicular. We break bones down into these two categories because of their likelihood to heal on their own. So each individual bone's blood flow and specific biomechanics affects whether it's a high risk or low risk site. High risk sites are much more likely to develop complications or to need surgery, while low risk sites can often heal conservatively on their own. High risk sites, because of their chance of complications, need longer time periods off. Often, this means 6 weeks of non-weight bearing to not stress the area and allow the healing process to occur. Once they finish those 6 weeks, they can start on a progressive rehab plan and then return back to the thing that they like to do. High-risk sites tend to take longer to return to running. They also tend to have a higher chance of complications, as I mentioned. The specific locations I see runners needing surgery most often are the navicular, the femoral neck, and the anterior tibial cortex. If a runner comes in and sees me and I'm worried they have a high-risk bone stress injury, I'm going to send them to a physician and advise them to be non-weight bearing until they get imaging, because it's much better to be conservative with these and backtrack than to allow them to continue walking and doing things, potentially increasing their risk of needing surgery. If a runner comes in with a potential low-risk bone stress injury, we often can continue doing things that aren't running and lifting. If they don't have pain, they may be able to walk and cross-train and maybe even do some exercises, because there's a less likely chance of them developing complications. This is described really well in this paper by Warden and colleagues. They cannot be having pain, but there's a chance they can continue to do things. And that's important, because if we can keep runners stressing their skeleton, even though it's to a lesser degree, they don't need as long of a road back to 100%. Unfortunately, sometimes runners are given the wrong advice. Remember, high-risk bone stress injuries have to unload, while low-risk bone stress injuries can continue to do something. Unfortunately, sometimes runners are told, hey, even though you have a high-risk injury, you can still do something. And so then what I have to do is say, actually, you can't do anything. You're going to do nothing. And vice versa. Sometimes runners are told, you have a low-risk injury. Don't do anything. Which, if they have pain, is potentially necessary. But often I have to tell them, well, actually you can do something. And we want to do that because we don't want to lose any more cardiovascular capacity, muscle strength, tendon stiffness, or bone density. We got to keep you doing something. If a runner comes in with a high-risk bone stress injury and they're told they can continue to weight bear and do things, you have to push back and say, no, absolutely not. And this is why. We've seen this specifically in the navicular, where patients that are allowed to continue to weight bear have much worse outcomes when it comes to conservative management. Just like if I have a runner that hasn't done anything for months with a low-grade, low irritability bone stress injury that's low risk, we have to get them doing something. So you have to understand your high-risk and low-risk locations. You have to understand their initial management strategies, and then at times, you have to be willing to push back if they haven't been given the best advice. If you'd like to learn more about these injuries, I would recommend reading the 3 studies that I've included in the description. Thanks again for watching.